I'm delighted to be here and really honored to be asked to speak at this lecture that remembers Alan Flisher. And I know that many of you in this room loved him very much, and certainly many people around the world as well. I'm going to speak to you today. Let me just figure out which things to move here. I'm going to be talking to you today about health disparities and health equity, and the roles that we all play in helping to reduce them. And I'm going to focus on the journey that we at NIMH have taken over the last 3 years, as we have thought for the first time really about how to engage these issues globally as well as locally. But I'm going to start with a story. I love Cape Town. Cape Town is the first city that I came to in South Africa 17 years ago on my first visit. But it has another significance for me, and that was 14 years ago, almost exactly to this day. Friends of mine and I was living in Johannesburg. We decided to take the long Women's Day weekend and take a trip to Lesotho. At the time, some of you may remember, Lesotho had just finished its presidential elections, and there had been some demonstrations in Maseru, and we weren't sure whether we should go or not, so we asked our colleagues at WITS, and they all said, "It's Friday, no one riots on a Friday." and so we went, and it was true. We drove through Maseru without a problem, just rush hour traffic, and we headed up into the mountains and had a lovely weekend hiking and horseback riding. We came back on Monday, drove through the capital, and it seemed like quite an ordinary day. There were people on the streets, there were a couple of kids in school uniforms, and we saw men on the street, and we continued to drive, saw a few more men, realized that we were actually driving into a crowd, and noticed that the crowd had angry expressions on their faces, and people were shouting at us and pointing. And we thought, well, we'll just keep going, we'll get through this, and we'll be fine. And in fact, we were not. Our car was soon surrounded by people. Several young men sat down in the street in front of us to block our road. People took large cinder blocks, brought them crashing down onto the side of the car. We were scrambling to try to lock the doors, and pretty soon we looked back and saw someone with a baseball bat bashing out the windshield behind us. I was sitting in the front seat next to my friend Debbie, who was driving, and I don't know how this happened. Somehow there was a path that opened up in the road, and there were people on the side of the road beckoning us to come this way, and we managed to pull off the road, where we got out of the car, which was a rental car, which was fully insured, fortunately. But it was pretty much destroyed, and shortly thereafter an ambulance drove through. They stopped and picked us up. A soldier got out and drove our car to the border, with his arm out the window, holding an automatic weapon very prominently as he drove through the crowd. We got to the border, and the people at the border were horrified and said, "This never happens in Lesotho. We're so very sorry. You just were in the wrong place at the wrong time." We drove back to South Africa, to Johannesburg that evening, and were shaken, obviously. The first thing that we did as a group, we wanted to stay together, and we felt this terrible anxiety. And talking was the first thing we tried. Drinking was the next thing we tried. It didn't really work. And as a psychiatrist, I think the week later, I realized for the first time, so this is what trauma feels like. And it feels like it's a surgical wound that actually has to heal. And you can't really use a Band-Aid on this, right? In that next week, I found myself driving in the Eastern Cape. I was doing a study at the time. Driving through the countryside, came to a village where there were many people roaming around in the street. And I saw these people in the street, and I simply couldn't go further. And I turned around and drove back. About 2 weeks later, I was in Cape Town. I had to come here, picked up my rental car at the airport. It was a beautiful day, very much like yesterday. Beautiful, sunny. Got in the car, a little nervous, but drove by the waterfront, and it was just gorgeous. I kept driving and ended up driving all the way down to the Cape of Good Hope. And I just remember that time as a time of this incredible beauty and this incredible peace. It was sort of like, I still remember the vibrancy of the colors, the greens, the blues of the skies, And it was kind of like having a good meal after a fast. And so I associate this with the sunny days here with this kind of healing and with this sort of renewal. And I felt much better after that. So, but I was lucky because I was not one of the 1.5 billion people in the world that are exposed to violence, war, fragile states, criminal violence on a regular basis. And nor was I someone who was exposed to a number of insults or distress in childhood. And I actually did not develop PTSD as a result of that. So there were many things protecting me in that particular situation. And I don't know what all of those factors were. But I can say that I am an African American, and therefore I am a member of a group in the United States that is subject to a number of health disparities. And we are still trying to sort out the various factors that influence that. We know that many of those are rooted in socioeconomic issues, historical context and social context, genetics, access to medical care. But even if you look at this picture, which shows you life expectancy since 1950, I see that there's a pretty wide gap. Fortunately, that gap is narrowing, and I think actually right now it's the narrowest it's ever been. This only goes to 2006, but there's more recent data, I think, to 2008. However, if you were to separate this by sex and look at white women compared to black men, you'd see a much wider gap. Again. African Americans in the United States have higher death rates than whites for 12 of the 15 leading causes of death. Blacks and American Indians have higher age-specific death rates than whites from birth through retirement. Minorities get sicker sooner, have more severe illness, and die sooner than whites. And some of these differences remain even after you control for socioeconomic differences. Hispanics in the U.S. have higher death rates than whites for diabetes, hypertension, liver cirrhosis, and homicide. So what about our health care? So this is kind of a complicated bar graph, and you may not be able to see the legend at the bottom, but this represents older people versus younger people, blacks versus whites, Asians versus whites, American Indians and Alaska Natives, Hispanics, and poor people versus high-income people. The fastest way to read this is to see that the green represents the areas of disparities that are worsening. The blue represents the areas that have stayed the same, and the black represents the areas that are improving. And things have gotten better for people age 65 plus in terms of access to care, and that's probably largely due to Medicare and the publicly available health that permits for folks. But otherwise, we're not doing so well with respect to disparities in access to care. Similarly, once people actually get access to care, this is the same legend and the colors mean the same thing here. There are disparities in quality of care. So again, the green represents worsening quality indicators. The blue means that things have pretty much stayed the same, and the black means that things have improved. So overall, on most of our quality issues, things are either worsening or they've remained unchanged. So now that I've presented that pretty picture, this is the context into which I was recruited to come and work for the government. I left academia, where we wore togas and spoke in the marketplace every day, and moved to the Department of Health and Human Services here, which is part of the U.S. government. And this box with a circle represents the National Institutes of Health. Other agencies in Health and Human Services that you may have heard of are the Centers for Disease Control, the Federal Drug Administration, things like that. But it's a big department. We call it the department, and we are a piece of that. So just to further orient you, NIH is the nation's largest medical research agency and the largest source of funding for medical research in the world. We're made up of 27 institutes and centers, and the National Institute of Mental Health is one of those. Two other centers that may be of interest to you, make a note of this, are the Fogarty International Center, which focuses on funding global work, particularly in low and middle-income countries, and the new National Institute for Minority Health and Health Disparities, which is dedicated to coordinating and funding research on health disparities in the U.S., but also funds global research. At NIMH, we call ourselves a matrix organization, but I haven't shown you the matrix. We have an Office of the Director, which has these offices that you see here on the left, and 7 divisions, one of which is our very own research division, where we have our own scientists who do primarily basic clinical and translational research. We have 5 funding divisions that range from neuroscience and basic behavioral science to adult translational research, developmental translational research, our division of AIDS research, and our services and intervention research division, which give funding and help set strategies for funding to extramural researchers, so all of you who are not at NIH. And finally, our extramural activities division, which helps get the money out the door. And the NIMH mission is to transform the understanding and treatment of mental illness through basic and clinical research, paving the way for prevention, recovery, and cure. And we're able to do this by conducting research, funding research, and supporting research training. We cannot, despite those grim pictures around access and disparities, we can't do anything about services except for study them and hope that the impact that the research has can actually make a difference. So, in 2009, when I came to the NIH, this was in the context of new president, and the White House had just announced its Global Health Initiative with a planned $63 million investment, mostly focusing on HIV prevention through PEPFAR and maternal child health, and some attention to neglected tropical diseases. There was also an emphasis on strengthening and leveraging partnerships, so partnerships with multilateral organizations and building on other kinds of engagement. Interestingly, there was also a women and girl-centered approach, which I think came from Hillary Clinton's influence to some degree. At NIH, there was also an interesting context around global health issues. Now, all NIH institutes were already supporting global research, but there was very little focus on equity. In fact, the majority of that investment was going to Canada, Europe, Australia, other high-income countries, and that's still the case. But the exciting thing was that global health was among the top 5 priorities of Frances Collins, our new director. At the same time, this was still an environment, and still is, with limited resources for funding. I think there were a few other confusing things around global health research at NIH that people in the research community were a bit confused about. And there's a policy, and this is part of the policy on international research, where one has to ask oneself, as you're preparing an application, will this project, will the proposed research project be enhanced through the use of unusual talent, resources, populations, or environmental conditions in other countries that are not readily available in the United States? Again, remember, we are an agency that's funded by the taxpayers, the U.S. taxpayers. And will the research have specific relevance to the mission of the Institute and potential for advancing health sciences in the United States? I think this policy often kind of stymied people in the extramural world who thought, well, given that there are limited resources anyway, and people often saw this as meaning, well, how is my research abroad going to have a direct impact on the U.S. population? So maybe, in fact, I shouldn't bother. But the nice thing about this is that it's about advancing health sciences in the United States. And I can say more about, I think, the implications for that in terms of global research. The other context at NIMH specifically, this is a picture of what our funding for international research looked like. These are direct grants to foreign institutions, and our distribution looked pretty much like the rest of NIH, where most of our direct grants were going to high-income countries. The gray is non-AIDS related research, and the blue is AIDS related research, and very, very few direct grants were going to middle or low-income countries. Now, with respect to foreign components, which usually means being part of a team and having a subcontract if you are the foreign investigator, much more of our global efforts were handled this way. Again, mostly going to high-income countries. In our institute's case, this meant mostly funding research on neuroscience and basic behavioral science. But with respect to what was happening in low and middle income countries, much of that was AIDS-related research. With respect to research on mental health disparities, there had always been research funding on mental health disparities. This was not new, but a strategy was needed that would help us, lead us to some measurable outcomes. And just to say a few words about mental health disparities in the United States. These are embedded in persistent socioeconomic differences. There are differences in income and wealth. Members of racial and ethnic minority groups are disproportionately represented in lower socioeconomic groups. And these same groups are less likely to access mental health services, more likely to receive lower quality care, more likely to use inpatient hospitalization and emergency rooms, and less likely to have community mental health service user access. Now, NIMH made some significant investments in trying to understand the prevalence of mental disorders among different groups in the United States. And one of these initiatives was the collaborative psychiatric epidemiology studies, which were among the largest studies of different racial and ethnic groups in the United States. And very interestingly, however, despite the fact that many of members of these groups were disproportionately exposed to adverse circumstances compared to whites in the United States, the prevalence of common mental disorders tended to be lower. So this is looking at studies of depression, anxiety, in this case. With the exception of a couple of groups, like Puerto Ricans among the Latin Americans, the others show fairly lower prevalence. Now, there were some other exceptions. American Indians tended to have higher rates of PTSD and higher rates of alcohol abuse. And among Hispanics and African Americans, we tended to see more persistent course of depression, with African Americans showing more chronic and disabling depressive episodes. And potentially, not in the common mental disorder group, but suggestions that there is a higher prevalence of schizophrenia in that group as well. So, what does some of this mean? Well, in the context of the way that the Institute of Medicine defines disparities, which means that disparities in care are related to those differences that you find if you're not looking at clinical appropriateness, you're not looking at need for care, and you're not looking at patient preferences. But instead, you're considering how does the healthcare system operate, you're considering is there discrimination happening in the interaction. When you look at these issues, this is one way of thinking of disparity. So an example would be that if you know that African Americans, for example, have a more persistent, chronic, disabling course of depression, and yet this is a group that's not accessing depression care, this would be disparate health services. This would be a disparity. And in fact, that is the case. So similar to the graph that I showed you looking at health disparities more broadly, access and quality, this one just looks at depression treatment and shows, again in the US, if you look at this side is looking at education. So the higher education, the more likely you are to have received depression treatment. These are people with college. These are people with less than a high school education. And on this side, it's grouped again by race and ethnicity with whites. This is the total. Blacks and Hispanics down here. So just to summarize, this is the situation. Tight budget, the mandate to do research to solve some of these problems, persistent mental health disparities in the United States for a very long time, expanding interest in global health across the government and at NIMH, but the need for a strategic approach to disparities and global mental health, and the need for research that could have a measurable impact on reducing disparities. So what did we do? And this is not really a what did we do, because this is ongoing. What are we doing as well? We rebranded, recruited, we did some reconnaissance, reframed, reviewed data to recognize gaps and opportunities, and we articulated priorities. One thing I've learned at this meeting over the last 2 days is that if you want to use an acronym, you can pick a letter from anywhere in a word and just underline it, and it counts. You can reach out and engage the community. And then finally, I'll talk with how we are and are trying to recognize broader opportunities in the global health community. So first off, when I arrived at NIMH, I was actually taking on 3 offices. One was called the Office for Special Populations, which really was focused on health disparities, but I think a number of us, as we talked about it in the office and around the Institute, realized that between the Office of Special Populations and the Office of Rural Mental Health Research, it really covered everyone except for white urban men. So it really wasn't that special. It was kind of the majority of people. So it seemed like it made sense to rename the office, and we combined the office and renamed the Office for Research on Disparities in Global Mental Health, marrying the Global Mental Health Office, which had not had a director for a few years, and the Special Populations Office, reflecting our sense that globalizing factors are important to consider when we think about disparities and when we think about research, and that nowadays researchers need to be thinking about populations within and across borders, because the determinants of disparities do not stop at national borders. So in the office, this is what we do. We focus on these 4 main areas: women's mental health. We house the Women's Mental Health Program at NIMH, rural mental health, as I mentioned, disparities, and global mental health. And there are 4 main areas of work. One is, of course, research, focusing on the research. What are the trends in these areas of science? How do we help guide the science? How do we fund research? A second area is the scientific workforce and research capacity building. Our efforts in the U.S. focus on diversifying the scientific workforce, ensuring that our research community actually represents the population. So we tend to have an underrepresentation of groups from low SES background, of disabled people, and racial and ethnic minorities, and so we work to try and change that. And then, more recently, in the last few years, we've really increased our focus on research capacity building in low and middle income countries. Reporting is something that our office does quite a lot. Whenever the White House, the Congress, the NIH Director's Office, or the Secretary of Health is interested in knowing something about tribal colleges and universities, immigrants, refugees, women, any of these groups, that usually comes to our office, and some reporting of some sort is required. And we have a nice team that works on that. And finally, outreach and collaboration, so making sure that we're working with other stakeholders that are also interested in these issues. So, recruiting. I was lucky to be able to bring on a nice team of people who've been really instrumental. Some of you know some of these people, and at least one of them is in the room, to help us begin this work and get some of this work done. And the next thing was kind of taking a look at who else is doing global mental health work. We knew that there were not a lot of funders, certainly in the United States. I mean, we always envied those people that had the Wellcome Trust and who were sort of eligible to apply, at least before I came to NIH, I always felt that way. But because there's not a lot of research funding for global mental health work, there's more for disparities in the United States. You can find foundations that will support in addition to federal funding. But we thought we'd look and see particularly what's happening in the NGO community. What are they doing around global mental health? So Jill Pace, who was an intern that worked with us, did a sort of quick and dirty internet search to find out what she could learn about global mental health, and particularly whether any global mental health research was happening out there in the NGO community. And this is just looking at what she found by income classification. Most of these organizations were from high-income countries, but a significant number, 36%, from middle-income countries as well. And some of them were web-based, so she wasn't really able to tell is there an actual country where this is headquartered. And then when you looked by region at these global mental health NGOs, Certainly, the largest number of them were in the Americas, followed by Europe, and then Africa came after that. And where are people working in these places? And again, the Americas and Africa were the main regions, the largest regions at least, where work was being done. However, she cautioned that the Africa region actually was mostly focused, many of these NGOs were working in Uganda or South Africa. And again, this might have to do with who is accessible on a Google search as well, more than anything else. We looked at funding sources and found that many of them were funded by donations and membership. But this is what we were interested in. What were the activities of these organizations? And education, advocacy, and policy were big ones, as well as providing direct clinical services. But research was certainly not a major piece of what these organizations do. And we thought, I wonder if there are organizations that we can engage around research as well as capacity building, which is this little pie slice there. So that was the global context. With respect to the local context, I think one of our tasks was to reframe the way that we thought about the separation between disparities internationally and locally. And I think that certainly is captured in the way that we define global health nowadays, in terms of global health not being about us versus them, not being about the high-income countries doing things to low and middle-income countries, but actually recognizing that we are an interconnected world and the relationships that flow from that interconnection. The United States is a wonderful example of this. Our last census gives an example of how we are a rapidly diversifying country. In the last census, the fastest growing racial group in the United States were Asians, and the fastest growing Hispanic group were Hispanics, both of which increased by 43% over the previous census. And this is largely due to immigration. If you look at this map, which just represents the land masses around the world, and then look at this map of international immigration, the U.S. is the largest receiving country of immigrants. And in 2009, 1 in 5 people in the United States were either a first or second generation immigrant. So it makes sense for us to think globally. It doesn't make sense for us as a country not to. And we have to be thinking about the diverse needs of our community. So part of that reframing was about adopting a global paradigm, adopting an emphasis on co-development, where we are expecting that what we learn as we work globally will also help us to develop what we do at home. And bi-directional learning, knowing that we can learn from what's happening in other countries just as much as collaborators can learn from those working in high-income countries. Research competence is another idea that I kind of like, which is the idea that as we do support global research, this research has to really be driven by the needs of end users, so that people, whether they are service providers, whether they are service users, whether they're policymakers, these people need to be a part of a conversation that helps to develop research activities that make sense and that can actually have impact. Part of our thinking also is that our research workforce must be global as well. We can't have only investigators coming from high-income countries or only from the wealthy and low-income countries. There need to be sustainable careers, first of all, however. It's difficult to sustain a research career in global mental health, even if you are at the US at a well-resourced institution. It's even more difficult, obviously, to sustain a research career if you are at a low-resource institution in a low-income country. There has to be room for non-traditional paths to research. I feel like this is something that Judy Bass has been talking about for a long time. Like, how do we make sure that we can take advantage and utilize the expertise that people who are working in NGOs, who are the first contact with populations, have, and how can they contribute to research? And finally, as I was saying, there needs to be a diverse and representative group of researchers that reflect the local population. So these are some of the foundation issues for doing science within and across borders that helped us to reframe the way we thought. So the next thing that we did was review. So what is the situation globally? And I'm not going to take a lot of time because all of you know this and many of you did the research that is on these slides. But just to remind you that mental disorders account for a huge burden of disease around the world. And this pink bars, which represent neuropsychiatric disorders, are burdensome everywhere. These are high-income countries all the way to low-income countries, representing about 30% of the burden of non-communicable disorders, and yet very few, certainly human resources to be able to deal with these. And I like this slide because it's so graphic, and that you see this enormous difference between the resources for psychiatric nurses in high-income countries versus the low-income countries, which are not even visible on this particular bar. Mental health financing, of course, there are also significant disparities here where spending in mental health is low everywhere. Less than $2 per person per year, but even less than 25 cents in low-income countries. And resources are not well utilized, with much of the investment in services going to psychiatric hospitals and psychiatric beds, and certainly not as many resources devoted to community mental health services. So our next issue was how to recognize opportunities. How do we recognize opportunities for global research? As I mentioned earlier, people have puzzled over the prevalence studies in the US, looking at differences among groups with respect to common mental disorders. We've not done as much of that work in the US with respect to schizophrenia. However, we're beginning at NIMH to fund research that looks at these mechanisms, that tries to understand the mechanisms underlying some of these differences. And we can certainly learn from some of the work that's been happening in Europe, looking at migration and the impact of migration on psychosis, for example. And you can see these tremendous differences in the incidence of schizophrenia in this UK sample among Afro-Caribbeans compared to Asians, and even among African immigrants as well. And similar findings with migrants, particularly Moroccans in the Netherlands. There have been a number of hypotheses around trying to explain these mechanisms, linking the risk for psychosis to living in a disadvantaged ethnic minority position, linking them to compromised family structures, to negative ethnic identity. But there have been a number of other things that people have hypothesized as well, including vitamin D deficiency, social capital issues, inflammatory set point. All of these are the kinds of mechanistic questions that there's the potential to answer when we're able to look broadly and look at populations around the world. Similarly, with respect to health care disparities, task shifting or sharing for mental health is an area of research that has seen, I think, tremendous leaps over the last few years, with an increasing number of clinical trials being conducted, and certainly with the collaborative hubs, we'll be able to strengthen the evidence around task shifting in different regions of the world, different healthcare systems. And this, in the US, is also quite relevant because one of the issues with our rural areas is the lack of healthcare providers, the lack of access. And I remember talking to a woman at a conference of advocates who was complaining that her son was doing a master's program. He lived in Wyoming or Montana, I can't remember which. But because there was really no training facility, no university nearby, he would have to travel, spend at least 3 hours driving in one direction simply to get supervision and drive back the same 3 hours on the same day once a week, and that this simply wasn't sustainable. So this was to be able to have a master's level provider, a mental health provider in a community in the Northwest of the United States. So finding ways of actually introducing technology and using technology in addition to task shifting in our country is also quite an important issue. So articulating, what's the next issue? Articulating a strategy. So where we got to after kind of walking through these steps and thinking about things, where we arrived at is this approach to prioritizing the way we think about research. And I've highlighted in yellow where we're going with this in the domestic disparities arena, and the white is the global mental health arena. So scientific opportunity is always one of the driving forces at NIH for any kind of research. I think the idea of looking at mechanisms underlying disparities, just solving tough problems with the best research. But focusing on equity is something that obviously we think is really important. And in our global mental health work, have chosen to focus on addressing the treatment gap in low and middle income countries, a glaring problem that for which there are certainly answers. And at home, that's meant addressing mental health care disparities in the United States, the care disparities as opposed to the status differences. Then a third prong of this is to anticipate and respond to global public health trends. And these include the demographic and epidemiologic transitions around the world. We're thinking about non-communicable diseases and how do mental illnesses interact with those diseases. Other issues related to an aging population. Number 4 is integrating mental health into global health platforms of care. This is partly just about taking advantages of existing resources. So if we want to build more research, can we build on a PEPFAR platform? Can we build on things that are already existing out there? In addition to making sure that those platforms now think about mental illness and mental health. Are people doing maternal child care with UNICEF thinking about mental disorders or thinking about depression in children? Are they thinking of these issues? And finally, supporting research capacity building in global mental health, while at the same time supporting efforts to diversify the U.S. scientific workforce. So, reaching out was one of those other R's. And we've done that through a number of meetings where we've been able to bring in members of the scientific community to help us think about disparities locally as well as disparities globally. And this has led to some interesting outcomes. And I'm going to spend a little bit of time, the rest of the time, really talking about this, the reaching out and what's come out of that. So our very first meeting that we hosted was this one in March of 2010, on the pulse of global mental health action, identifying strategic research opportunities. And the goal of that was to get a small group of people together to help us think about research directions for reducing the treatment gap in low and middle income countries. So we invited representatives of mental health NGOs from around the world, mental health policymakers or people working in ministries of health in low and middle income countries, implementation researchers working in these settings as well. And we asked them what research is needed to reduce the treatment gap and what stakeholders need to interact to be able to produce service-relevant research and to scale things up. That group had a spirited discussion for a couple of days, and what we took from that conversation led us to develop this initiative, the Collaborative Hubs for International Research on Mental Health, which we're so excited to be here for this week, for the launch, really, of this first hub meeting. And what was interesting about this initiative was that we first required people to conduct research around task shifting so that we could get at these issues of how to extend the human resource workforce. But we also wanted to see how those of you out there in the extramural research community could think about research capacity building for regions, not simply for one country. And I think that what we were most excited about and what's been most interesting to see in these groups is your collaborative efforts and your collaboration with end users. How are you working with government and NGOs and service users, getting those viewpoints and making sure that the research that you do serves these people. And the fruit of that are these 5 hubs, which Crick mentioned: the African focus on intervention research for mental health, working in South Africa, Ethiopia, Ghana, Malawi, Uganda, and Zimbabwe. Ready Americas for Argentina, Brazil, Chile, and Colombia. Our new Latin MH with Brazil, Colombia, Ecuador, Guatemala, and Peru. SHARE, the South African Hub for Advocacy, Research, and Education on Mental Health in Afghanistan, Bangladesh, India, Nepal, Pakistan, and Sri Lanka. And PAMD, every time I look at that, I'm thinking, oh, that's my name. in Nigeria, Liberia, Kenya, Ghana, and South Africa. So we're really excited about these. Now, another one of our reaching out efforts was to engage the global community around priority setting for mental health research. And again, many of you in this room were involved in that as well. This effort with the grand challenges in global health to identify priorities. This was an effort that led to the recruitment of 422 people from around the world, from 60 different countries, that ultimately identified 25 top challenges and 6 goals with attendant research questions. And one of the follow-up steps to that, from our perspective, we're certainly not the only ones who've done this, is focusing on one of the grand challenges, which was around integrating mental health into chronic disease care. So building those relationships between mental health researchers and HIV/AIDS researchers, mental health researchers, and people working on non-communicable diseases, mental health, maternal child health, other platforms of care. So we're looking forward to seeing what comes out of that as well. So interim results for a lot of this effort has been opportunities to target research and to fund research around training, domestic disparities issues, and global implementation research, primarily in low and middle income countries. And I think one of the more exciting and fun things that we've been doing is also reaching out to a new generation of researchers, young people interested in global mental health. Also in 2010, we held a meeting which we don't think anyone, certainly in the US, had done before, which was to bring together people that wanted to do global mental health. And we weren't really, we said we were talking about global mental health research, and we kind of got people that wanted to do anything related to global mental health. But we had about 40, we had a selection process because we couldn't actually bring everybody that expressed interest. But we had a selection process that led to about 40 people coming together, and we asked them, tell us what we can do to help you. What do you need from us as an institute to help you kind of launch your research career, sustain it, and get it going? And people said everything from, we need to get into the field. How do we do that? We need funds to first get some of these experiences. This is what we want. We had some senior faculty from different institutions around the US also talk about their global health career, their global mental health career experiences. We had people from NGOs, again, talking about what are the most important things to think about as a researcher if you're going to go and work in these areas. We were able to follow that up with a collaborative effort with the Wellcome Trust that enabled us to bring a smaller set of young trainees to South Africa in October to the World Mental Health Congress, where they had a chance to meet many senior Wellcome Trust investigators. And right now we're working on how to begin to make sure that we can evaluate our efforts in developing and sustaining this young group of investigators. One of the other outcomes has been Global Tracks, which is our electronic newsletter focused on global mental health career development. If anybody wants to receive it, send me an email and we'll sign you up. And I think another concrete outcome of this has been when I first got to NIMH, and even during that meeting, when we looked at, okay, well, what would be a path of funding? Is there a path of funding that could take you from, let's say, your pre-doctoral, let's say you're a medical student, or you're a public health graduate student, that could carry you from there to independent researcher? We had a few question marks in this arrow. But over the last year, we've actually been able to fill in these squares so that students in the US can begin to receive fellowships that give them experiences to do global mental health research. They can move on to postdoctoral research. We now have 2 postdoctoral research programs specifically focusing on global mental health. They can move on to mentored research awards and then on to other kinds of mechanisms. But just as exciting is that the same is true for people who are not in the US, that there are now a series of training opportunities for non-US citizens living in low and middle income countries through which they can get involved in training. And the hubs obviously are going to be one of those resources for training as well. And we can't do any of this alone, and we have also worked to collaborate with the World Health Organization and MHGAP with the Global Alliance for Chronic Disease and Grand Challenges Canada, and other funders that are here. This is an interesting article in Science showing global mental health funders and showing the increase in funding from multiple organizations, and we're very enthusiastic about that. So this is just to remind us that global mental health research is one little piece of the bigger goal of global equity. Global mental health research hopefully can lead us to increase global mental health equity, which is a part of global health equity, which is a part of the bigger picture. And I think that as researchers, the next step is to think about what happens beyond the research to policy and to other arenas. Certainly, research is not the only thing that's going to create equity. We need legal and policy reform. You need civil society and community engagement. You need global governance for health. But we also need research that can examine the impact of what policies do. From research to development, how is it that the research can influence development? I'll tell you a quick story. USAID has been holding a series of evidence reviews with Rajiv Shah, the new administrator. There's been much more of an emphasis on how what USAID does should be evidence-based. Recently, I attended one evidence summit that was focused on community health workers. And the task was to look at what community support activities, what formal health system support activities, and what combined support activities actually improve the performance of community health workers. Interestingly, when you look at the literature, and there was a huge literature review that accompanied this, especially when you look at number 3, are there examples where we can actually see how communities as well as health systems support the work of community health workers, and what is the impact on their performance? There's really not much there. I mean, many of what we do find in the literature shows that a research team trained community health workers, but that next step of sustainability and how that was sustained isn't there often. So I think that's certainly a task for the hubs to actually fill in that piece of the data, because donor organizations are looking for that kind of thing. They want to see the examples of that. And finally, how are community and formal health system support activities structured or operationalized to improve community health worker performance? And certainly looking forward, looking ahead to the Sustainable Development Goals, which will likely follow the Millennium Development Goals, what is the role of mental health research there? Jeff Sachs and others are already thinking about happiness, and thinking about happiness as one of the measurable outcomes for sustainable development, with mental health being a sort of subset of that. But I think this is an opportunity for us to say, what are the ways? How does it make sense for us to contribute to this thinking and to this line of work? And with that, I'd like to acknowledge the Office for Research on Disparities in Global Mental Health and the many people there who have contributed or continue to contribute to much of the work that we do, who are actively engaged in task shifting and sharing as well, and the larger institute. So thank you.
Thank you very much indeed, Pamela, for a very stimulating and informative talk. I think it's very interesting, especially for those of us who work in research, to hear the perspective of funders and hear your broader strategic vision for this work. So thank you very much. We have some time for some questions, comments. The floor is yours.
Yes, comment. I just want to acknowledge that probably must be aware of it, because it's easier to see close up in the US. Pamela, you completely transformed the landscape in disparities and development research since you arrived there. It's unrecognizable just to acknowledge that, you know. And then one suggestion, a little bit trivial, but you could say re-articulate. And then it's all
confused too.
Thank you very much for this really conference. We had a discussion with Chandra. She was telling us about how we as students will apply for NIH shuttle. And I wonder about how international students, not established researchers, could also access funds for research.
So the question, if you didn't hear it, was about how can students who are not in the U.S. access funds for research. And that's a complicated question because, first of all, most of our training mechanisms are specifically for U.S. Either residents in the U.S. or citizens in the U.S. However, Fogarty International Center does sponsor opportunities that can provide research training. When you say student, I think you have to figure out what level. I mean, most of the research training activities that would happen through Fogarty mechanisms, or even those that we support. So we also support. So for example, we will fund something that's focused on mental health training that comes through Fogarty. So we'll work in partnership with them. And an example might be, for example, a training program for doctoral research training in Vietnam on mental health. But it's going to be something that's a particular set of investigators have developed with their colleagues in a particular country, most likely, or perhaps in a particular region of the world. But it's open to people from that region. So you first have to find out where those are, where those programs are currently existing, and then how to get access to them. The Medical Education Partnership Initiative, which is a partnership with NIH and PEPFAR, is permitting some research training but that's specifically for people that are in medical education, though. So, and those again are specifically for the countries where those PEPFAR, where those MEPI awards are. And right now we have one award in Zimbabwe, and we're about to fund another African award as well. So it takes a little digging, but you can always email us or contact us, and we can try and help you get that number.
Thank you for that really inspiring talk about and also hope for the future going forward. But then Israel made the point that a lot of this is due to your leadership. You in your talk were actually kind enough to say, no, there are a lot of other people, other organizations that have led to this. So I'm just wondering, what do you see as, how will things turn out? Is this a blip that happens, with a lot of factors that led to this?
I'm looking for my crystal ball.
And you mentioned tying into sustainable development going forward, but then, for example, mental health wasn't that closely tied into the Millennium Development Goals. So, tell us what's in the crystal ball, please.
It's a good question. I mean, at least if you look at the happiness report, right? And they're actually trying to articulate outcomes. So how can we actually measure happiness, which includes physical health as well as mental health outcomes, at this early stage. So I guess some of these are about how do we in this field take advantage of influencing some of these processes at the beginning, and perhaps we can see them articulated in those goals going forward. I'm not savvy enough about the politics of that to know, how realistic and how much of an impact one can make, but it never hurts to try. And certainly, I think about the big efforts that were made with folks leading up to the last UN General Assembly meeting on non-communicable diseases to get mental health into that. And although that didn't happen in the way that I think the mental health community would like, there's certainly been movement, on global mental health with WHO's mental health action plan and other things coming up. So, and I guess this whole issue of integration is one that, and I know some people disagree with this, that we shouldn't be trying to kind of tie mental health onto the back of other things. So we shouldn't be focusing on mental health and HIV or mental health and maternal child health. I have colleagues that would say that that's the wrong thing, and that we need to be just advocating for mental health in its own right, regardless of other. But I actually think it makes sense to do this. And certainly having been in Washington now for a couple of years and having a chance to talk to people, people that are not in mental health, they don't see it. You know what I mean? It's not even when you would expect it to be obvious, like after a disaster, even in those times where people are still very focused on their infectious disease, they are focused on the things that they do. And unless you can find a way to show them that what you do is relevant to them, I don't think, at least in policy circles, it's easy to move that. So I think part of that conversation. The other thing that I've often heard from people in the development arena is, well, the reason mental health was not included in the non-communicable disease agenda is that you don't have simple answers. You don't have simple prevention tools. So we can say exercise, proper diet, reducing salt. All of these things can help a range of non-NCDs. But what can we say about mental disorders? And I think there's a responsibility that we also have as a community, because I've been in meetings where there's that conversation, and the mental health people that are there will have completely divergent views about what mental health is and how we define it and what we need to do to go forward. So it makes it even more confusing for the non-mental health people that are trying to figure out how to use their donor dollars. And as one person from USAID just told me, there are just too many priorities, and I'm sorry, people aren't dying of yours. But yeah, so I do think part of what we do going forward is to help people to understand the relevance. Because as much as I say those sort of negative things, I also once received a call from a young guy who was doing an internship at USAID, who had been calling around NIH trying to find out who the person was to talk about. And people sent him, they said, did you know that mental illness is related to some infectious diseases? Like, does anybody know this out there? Like, we're really amazed. I'm like, how come nobody's talking about this? And I think, we often preach to the choir, and people can discover little nugget of information that are not in our circles, and they're amazed. Wow! So I think that communication and finding how to link up is important.
Thanks very much. I'm really intrigued by the role that the institution playing, sort of facilitating sort of expert understanding of current challenges. I think that's something that the local hubs could help facilitate at the local level. So, for instance, I know the health department of the Western Cape is very interested in this question of integration of those national interviewing across a range of conditions, and perhaps there's an opportunity for the centre and the hub to facilitate the discussion between the evidence from all the hubs together, so that policymakers can run this, because I think they are interested in services that integrate across conditions, and they're interested in.
That's a great question. Yeah, I mean, we're kind of thinking that these are going to be magical hubs that do everything. So maybe so. I mean, I think that's an interesting question, and certainly a resource.
All right, well, thank you very much indeed. If I can just again, just in closing, I'd like to acknowledge Alan Flisher's sister who's with us today and able to join us, and to thank you very much for being with us, and to convey our greetings to Alan's family.